Greetings. Let us talk about acute pancreatitis and figuring out what has precipitated this acute pancreatitis. In other words, finding out the cause for acute pancreatitis. I would like to thank my mentor, Dr. Stroline, Mr. Charles Butt, Ms. Angela Deal, my institution, and my mentors. Please read this notice. So here is this beautiful, healthy pancreas, and this has become inflamed. In other words, pancreatitis. Patient presents with abdominal pain in the upper abdomen, especially in the epigastric region, deep boring continuous pain lasting for several hours with radiation to the back and associated with vomitings. And you have checked the amylase and lipase, both are elevated, and when you compared it with the upper limit of normal, they were significantly elevated, at least more than 3 times the upper limit of normal. So with the pain and elevated pancreatic enzymes, you thought that the patient has acute pancreatitis. The commonest cause for pancreatitis, especially in a woman, is gallstone disease. And in gallstones, what happens is whenever you have multiple small gallstones, they escape from the gallbladder, come down the cystic duct, bile duct, and then get stuck at the ampulla of water, resulting in pancreatic duct blockage and setting off acute gallstone pancreatitis. So gallstones accounts for at least a third, or if not more, in terms of the etiology of acute pancreatitis. So this is especially true if you see a woman who is in her 40s or 50s. She is fertile with lots of kids and fatty or obese. So whenever you have all those, you think about gallstones and gallstone pancreatitis. So how do you make a diagnosis of gallstone pancreatitis? So if the patient has elevated amylase and lipase, and a blockage of the bile duct could elevate the liver enzymes, AST and ALT, but you also want to show that there are gallstones. So you go about doing that by ordering a gallbladder ultrasound. So here is a young lady performing gallbladder ultrasound, and you can see the gallbladder under the liver, a nice thin wall, it's not inflamed. And as you scan, you notice multiple gallstones. Multiple small gallstones are necessary for the stones to escape down the cystic duct into the common bile duct and block the ampulla of water to cause pancreatitis. So whenever you see filling defects in the gallbladder, you have to differentiate between a stone and a polyp. Stones cause shadowing behind the stones. So that is something you have to keep in mind to make a diagnosis of gallbladder stones. Say, for example, you performed an ultrasound and you did not see any gallstones, but this is a woman or in anybody coming in with pancreatitis. If the initial ultrasound did not show stones, it is important to repeat the ultrasound a week later. That might show stones, because if the patient has gallstone pancreatitis and you missed the diagnosis and you did not perform cholecystectomy, patient will come back again with much more severe problem. So it's always important to rule out a treatable cause for acute pancreatitis, and a treatable cause is gallstone pancreatitis, and the treatment is cholecystectomy, and the patient should undergo cholecystectomy before he or she leaves the hospital. So very important to keep that thing in mind. So this is something to keep in mind. Ultrasound, stones, you're good. Send them for cholecystectomy if they had mild pancreatitis. Ultrasound, no stones, but you still think that there may be suspicion of stone disease. Repeat the ultrasound in a week to see if there is sludge or small stones or microlithiasis that you may find that could benefit from cholecystectomy. So every patient coming in with pancreatitis, you should ask for alcohol use history. So not social drinking, a little bit of alcohol now and then is not going to precipitate pancreatitis. So when you think about one beer, it has 14 grams of alcohol, and if somebody is drinking socially, a beer, or for that matter, a glass of wine or a shot of whiskey, they all contain 14 grams of alcohol. That history, you should not automatically assume that the patient has alcoholic pancreatitis. The answer is no. You need to have heavy alcohol use, at least 50 grams of alcohol per day for a long time, at least 5 years or more. So you're looking at, if it is 50 grams, you're looking at 4 beers per day or 4 glasses of wine or 4 shots of whiskey. So I wanted to keep this thing in mind so you know that a beer, a can of beer, a glass of whiskey, and a glass of wine or a shot of whiskey, they all, irrespective of the volume, contain about 14 grams of alcohol per each unit. So you need to calculate at least, they need to have at least 4 of beers, 4 glasses of wine, or 4 shots of whiskey to say, hey, heavy alcohol use, and that has to go on for at least a long time, a few years. So that is something to keep in mind. Otherwise, if somebody has pancreatitis and you take history and they say, hey, I drink some beer, maybe on the weekends 2 or 3 glasses of wine or whatever, you should not say that's pancreatitis related to alcohol, because you may miss another correctable factor if you assign the diagnosis to alcohol use. So in summary, 2 most common causes of pancreatitis. Look for gallstones and make sure that you don't label somebody as having alcohol-related pancreatitis unless you have a history of heavy alcohol use, more than 50 grams per day for at least more than few years, 5 years. And these gallstones and heavy alcohol use account for at least 2/3 of the, or even more, in terms of etiology for acute pancreatitis. I hope this is helpful. Thank you.